All right, hello. Today we are going to be talking about frontotemporal dementia, otherwise known as FTD. My name is Bella Genovese.
McGirding.
I'm Jade Hamrick.
And I'm Haley Happel. And first, we're going to start off by defining FTD. FTD is usually found in individuals under the age of 65 and is the third most common cause of dementia and the second most common cause for early onset dementia. So here's a brief list of some of the things or the following features of FTD. So there's memory problems, there's impaired executive functioning, behavior changes, loss of empathy, and the list goes on. And so the incidence for FTD is 2.8 out of 100,000. So this just means that 2.8 out of 100,000 new cases of FTD occur every year. And then according to this research article from 2025, the prevalence rate of this is 9.17 out of 100,000 cases, meaning that 9.17 out of 100,000 people living with FTD live with it currently. So the etiology of this is FTD is a sporadic disorder, meaning that while genetics can play a role, only 40% of FTD cases are hereditary, 13.7 of genetic inheritance are autosomal dominant inheritance. So that means only one out of the parents would need to pass a gene mutation down to the child for FTD to be inherited. There are 20 discovered mutations that can be potential causes for FTD. And then interesting fact here is head trauma and thyroid diseases have been correlated to FTD. As you can see, head trauma has a 3.3-fold higher risk of developing FTD, and thyroid diseases are 2.5-fold higher risk of developing FTD. And then here we move on to the neuroanatomy. So here's like a general brief overview. So it really damages the frontal lobe in the prefrontal cortex and motor functioning area. So that just deals with the reward center, planning, decision making, comprehending social situations, and understanding language. That's commonly damaged in FTD. And then a subcategory of that prefrontal cortex is the dorsolateral region. And this specifically deals with executive functioning and is damaged as well. And then we have that frontal temporal region damage. So that's Broca's area, Wernicke's area, which is understanding language and controlling impulsive behavior. And then we have the temporal region. So you see the medial temporal lobe damage, which is episodic memory, and then anterior temporal lobe, which is connected to motor speech output. And then here we just have pictures from like the slides previously of the different places of damage to the brain. And then here's part two of this. So then we have different subtypes of FTD, which is really interesting. So we have the behavioral subtype, which alters behavior and personality. Then we have semantic variant primary progressive aphasia, which deals with language deficits and impaired wording formulation, and then non-fluent variant primary progressive aphasia, which is difficulty in speech production and language formulation. And so why does this matter? Because various parts of the brain are more damaged and affected based on the specific subtype of FTD. And in that image next to it just shows like the different areas of damage based on the color, which like cooler colors, there's more damage. And then, so for the behavioral subtype, is found to affect the anterior cingulate cortex, anterior insula, striatum, amygdala, hypothalamus, and thalamus. And then atrophy can also be found in the orbital and mesial frontal lobes and anterior temporal lobes. And then dorsolateral prefrontal systems are affected, which can affect the person's ability to problem solve, organization, and planning. And then the stages of dementia and progress usually start from the orbital and mesial frontal lobes and then just end in the dorsolateral frontal cortex and the basal ganglia in that behavioral subtype. And then in the semantic variant subtype, the disease starts progressing the left anterior temporal lobe and then makes its way contralaterally as the disease progresses. And then in the later stages, it moves to the orbital frontal and then posterior brain regions. Then the more severe on the left temporal lobe than the right. And then compared to Alzheimer's disease, temporal lobes were damaged bilaterally more. And then this is predominantly observed to be in the area where anomia takes place, as well as decrease in word knowledge. And so also just an interesting little tidbit here is the diffusion tensor imaging shows that there's higher diffusivity, higher parallel and transverse diffusivity, and decreased fractional anisotropy within the inferior longitudinal fasciculus, accruent fasciculus, and uncinate fasciculus. And then the corpus callosum has decreased fractional anisotropy when studied. And then the non-fluent variant progressant aphasia subtype affects the dominant inferior frontal, anterior insula, and the superior temporal gyrus.
So there are quite a few deficits that arise from FTD. These can include executive dysfunction, which is seen through poor planning, organization, and sequencing. This can also be seen through impaired attention and more difficulty with planning. Behavioral changes can be seen through increased impulsive and compulsive behaviors, as well as a loss of motivation. And social cognitive deficits can be seen through lack of emotional understanding and connection, difficulty with social cues, which then could lead to a difficulty understanding other people's perspectives and views. And there is a loss of empathy that is associated with this disease. More deficits of FTD include language and functional impairment. Language deficits can be seen through trouble of finding words and increased difficulty with comprehension, just an overall confusion. And functional impairment is a broad term, but it can be seen through declining of daily functioning, like inability to manage work responsibilities and social responsibilities, and an increase of loss of independence. Through understanding the neuroscience, the previously discussed deficits will align. The anterior temporal lobe is responsible for understanding of social meaning. It controls knowledge of people, emotions, and relationships. So damage to this would lead to a loss of empathy, difficulty recognizing emotions, and misunderstanding social cues and situations. For example, someone with FTD might not understand when or if someone is upset. The orbitofrontal cortex is responsible for adjusting behavior to specific contexts. It inhibits inappropriate actions, so damage to this leads to increased impulsivity, socially inappropriate behavior, and loss of manners. The ventrolateral prefrontal cortex is responsible for decision making and behavioral flexibility, and damage to this would lead to inappropriate decisions and poor judgment. An article by Rouse discusses how social behavior depends on both the temporal lobes and frontal lobes in FTD. These systems fail, leading to individuals becoming more emotionally unaware, impulsive, among other deficits. This image shows where the deficits arise. The purple in this image represents the anterior temporal lobe supporting social semantic knowledge. The yellow in this image shows the orbital frontal cortex in which the social control is supported, and the ventrolateral prefrontal cortex is shown in cyan. So FTD causes behavioral and social deficits because it damages brain networks that are responsible for understanding social cues and meaning, therefore controlling behavior. This leads to a combination of lack of empathy, disinhibition, and poor decision making. There is no specific treatment that can prevent FTD, but the main objective for FTD is just to relieve symptoms and improve patients' comfort. So SSRIs, selective serotonin reuptake inhibitors and analogous treatments can be used. And as an OT, OTs just assess household safety and mitigate risk of falls and provide support in daily tasks for those struggling with fine motor manipulation and apraxia.
Okay, there are several activities impacted by FTD. Two activities specifically mentioned in the research article we referenced were household chores and eating tasks. Individuals with FTD often struggle with maintaining a structured daily routine, which can lead to the inability to manage basic household chores, such as cleaning, organizing the house, doing laundry, financial management, and meal preparation. Individuals with this condition struggle with complex instrumental tasks due to symptoms like loss of motivation, executive dysfunction, and memory impairments, like we talked about earlier. As this disease progresses, individuals also struggle with eating tasks. FTD involves the decline of both physical and mental abilities in individuals, which can include swallowing, chewing, and impulse control. The progression shifts from mental difficulties like motivation and lack of interest to more physical issues that can pose a safety risk to those individuals, like choking. Patients may also exhibit binge eating behaviors and dietary shifts that can pose other health risks. The peer-reviewed research article we found investigates the efficacy of occupational therapy interventions for individuals with FTD. The study focused on individuals with various forms of FTD and their primary caregivers that were involved. The review integrated data from 11 different studies that met the inclusion criteria for this research study. The study was conducted according to PRISMA guidelines to ensure a systematic and transparent approach. They did this by searching databases for peer-reviewed research that was published between 2003 and 2023. And the sample sizes from this study ranged from individual case reports to larger clinical trials of up to 145 individuals. When discussing the findings of this research article, it was concluded that OT interventions effectively reduced socially inappropriate behaviors by teaching patients acceptable alternatives to their behavioral responses. It was also found that structured sessions, including tailored activities to the client that applied to them, such as music, art therapy, gardening therapy, they all led to significant improvement in the patient's apathy, decreased anxiety, and decreased aggression. And then OT interventions not only improve the quality of life for those that have FTD, but also the lives of the caregivers that are involved. Interventions were shown to have significantly reduced the caregiver burden and increased their confidence and vigilance with their care. And then the last major finding of this research article showed that moving patients to a group home setting in a more home like, patient centered environment significantly improved their behavioral symptoms, their daily structure and routines, and reduced the need for psychotropic drugs.
All right, and now we're going to talk about how the article supported OT interventions. So, in a baseline format, OT interventions we know contribute to an individual's improvement in quality of life, right? Through realistic goals and treatment sessions that are going to offer a just right challenge to the client. So, OT interventions based on FTD provide a variety of enhancements for not only the individual, but their family and caregivers as well. So, we know that caregivers are oftentimes burnt out due to their heavy and important role in that individual's life. So, education on preventing caregiver burnout is vital. Additionally, as previously discussed, structured routines are very helpful in OT intervention sessions for those with FTD. So, this may include things like sticky notes, routine checklists, and daily structured routines. And then collaborating with the individual and their caregivers or family is a great intervention so that we can discuss environmental modifications inside and outside of the home, along with assistive technology or devices that can increase participation to meaningful occupations that this individual can no longer fully participate in. And overall, the article suggests that tailored OT interventions can not only enhance the quality of life, but slow down the decline of FTD while simultaneously reducing caregiver burnout. And now we're going to talk about two OT assessments that can help us figure out FTD. So the first one is the Cognitive Performance Test, otherwise known as CPT. So the CPT is a performance-based standardized assessment that includes 7 subtypes that correlate to ADLs and IADLs, which include medbox, phone, travel, shop, wash, toast, and dress. It is administered by having the client complete all 7 subtests, which takes around 45 minutes, so it's a little bit lengthier. The administrator will verbalize all of the instructions and be available for minimal questions and cues during each subtest for the client. The CPT overall measures how the cognitive deficits impair an individual's ability to complete these everyday tasks. Each subtest is then given a score. Then we sum up all of these scores on a scale of 5.6 to 1 for a CPT profile. And then anything under that range is going to show us cognitive deficits and challenges in FTD. And this just talks about how the individual will have at least a mild cognitive functional decline and will show not only poor executive functioning, but be unable to properly complete ADLs and IADLs. And overall, these findings are going to guide OTs to create realistic goals and intervention plans within the individuals that have FTD. And then right here, I just have an image of the CPT and then its functional profile levels and an explanation of those. All right, and then lastly for the OT assessment, we have a Montreal Cognitive Assessment, otherwise known as the MoCA. And the MoCA is a very quick pen and paper performance-based assessment that includes 16 items across 8 domains. And those 8 domains are the visuospatial, executive, naming, memory, attention, language, abstraction, delayed recall, and orientation. The MoCA is administered by having the client complete all 16 items, which only takes around 10 minutes. So it's significantly shorter than the CPT. The administrator will ask the client questions or instruct the client to actually perform an action based on each item. The MoCA measures mild to severe cognitive dysfunction through its rapid screening. And then, similar to the CPT, each domain receives that individual score. We then sum up all of those domains to receive the total, and that can range from 30 to 0, 30 with normal cognitive function to 0 which is severe cognitive impairment. And then anything under that score is going to indicate some cognitive deficits and challenges in FTD. And very similarly, again, the individual is going to have at least a mild
functional decline, along with the poor executive functioning, and then along with not being able to fully participate in ADLs and IADLs. And these findings are truly just going to guide OTs to determine what the best next steps are for the client and their caregiver. And then there is the picture of the MOCA split up in two. And then there are references.